first few hours, treatment may involve special medications to help to dissolve the blood clot, called intravenous thrombolysis, or procedures to remove the blood clot, endovascular therapy. Patients often have to be on blood thinning medications to prevent further strokes. The type of blood thinning medication will depend on the underlying cause. The neurologist will advise on investigations and treatment. About 20% of strokes are hemorrhagic strokes. In a hemorrhagic stroke, there is bleeding in the brain. This can be related with high blood pressure or sometimes abnormal blood vessels in the brain. Sometimes surgery by neurosurgeons or procedures by interventional radiologists may be required. The Singapore Stroke Registry annual report states that there has been an increasing incidence in stroke from 2012 to 2022, with an increase in stroke episodes up to 9,702 in 2022. I would like to take this opportunity to share this infographic from Health Hub, which teaches one to think fast in spotting a stroke. If you notice your friends or family have any of these signs, drooping of the face, arm weakness, or difficulty talking, call an ambulance 995 immediately and go to hospital. Depending on which areas of the brain are affected, people can end up with different impairments. In some cases, the stroke may affect multiple parts of the brain. There may be weakness of the hands and legs. The hand and leg movements are controlled by the opposite side of the brain, meaning that the right side of the brain controls the movements of the left upper limb and lower limb. If the stroke affects the right side, there can be weakness of the left side. There can be problems with numbness, loss of sensation or altered sensation, and in some cases, even pain. There can be problems with coordination, meaning control of movements, which can affect the ability to use your limbs in tasks including walking. Swallowing, which is also controlled by muscles, can be affected, and sometimes a feeding tube may be required. There can be problems with vision, where there can be changes to the field of vision. For example, only half of the field of vision is appreciated. In some cases, blindness can also result from a stroke. There can also be cognitive changes with problems with attention, memory, executive function, for example, making decisions. In the early stages, people may have problems with arousal or staying awake as well. Patients may have neglect, and this is a medical term that refers to a lack of awareness. For example, a lack of awareness of one side of their body or even one side of the environment. This differs from a vision problem. I present it quite simply, but neglect can be quite a complex impairment to have. There can be communication problems, for example, speech that is unclear, what we call dysarthria. Sometimes there can be a problem called aphasia, where people may have difficulties with understanding what is told to them or difficulties with talking, producing the correct words to answer something, or even difficulties with producing sound. They can have problems with reading and writing as well. Once again, depending on the area of the brain affected, sometimes patients can present with other symptoms like giddiness or nausea. There can also be personality or mood changes, commonly with problems like low mood or anxiety. Quite often, there may be a mix of problems. Another concept to understand is that everyone is unique. Everyone's brains are unique. And sometimes, even if a stroke is in the same location, it can present differently for another person. And that's where I always advise people against making comparisons with other friends or family. Recovery can be a journey, and it's important to understand that everyone's journey might be a little bit different. It's not just what happens in the hospital, but also what happens after discharge. There are different phases in the stroke recovery process. The acute phase, which occurs roughly up to the first week, is followed by a subacute phase and then a chronic phase, which may be roughly from the first 6 months onwards. In the acute phase, patients may need investigations or specific treatment, as mentioned earlier, to stabilize their condition. This is guided by the neurologists or neurosurgeons. As shown in this figure, the initial acute phase, there may be inflammation and swelling that occurs. A large part of the recovery of the initial stage may be related to resolution of this. When patients are medically stable, rehabilitation can begin. Literature does say that the most amount of recovery usually occurs in the first 1 to 3 months. While everyone recovers to different extents, an important point to note is that sometimes recovery can continue beyond the subacute phase, up to 1 to 2 years after a stroke, which is why, as mentioned earlier, it is a journey. One of the foundational concepts in stroke rehabilitation is neuroplasticity. This is the brain's ability to reorganize itself and adapt. It is not about regeneration. Once the brain cells die off, they don't grow back. Instead, it is about creating new connections and new pathways in the brain network. This is based on learning and experience, which help to shape the brain, even in healthy people. When we learn new skills, the brain changes, either by adjusting how the areas are connected or how they're represented within the brain. For example, learning a new movement can cause a larger representation in the brain for control of that movement. Experience or training affects how much the brain changes. For example, a trained musician or athlete has different brain patterns compared to someone without that training. Even in musicians, the brain shows differences between their skilled and unskilled hands. These skilled movements usually come from lots of practice, like when we learned how to write alphabets when we were young. With more training, there can be more changes in the brain. In stroke rehabilitation, there is also the concept of task-specific training. If the ability to perform a particular task, such as dressing, is lost after a stroke, then it requires specific training of that task to relearn it. Of course, this may include foundational steps that build upon one another to achieve this. And it also depends on the impairments and the severity of the impairments involved after a stroke. Research has also shown that enriched, complex environments support recovery. This is something that all rehabilitation units strive to achieve through the various therapy activities. Broadly speaking, rehabilitation treatment approaches can be restorative, helping to regain the particular impairment, or adaptive, helping to compensate for the loss of an impairment, but helping to regain function. Sometimes there may be a need to integrate and mix the two approaches. There are many interventions that can help with recovery, and we will touch on some of them later today. So this list is definitely not exhaustive. Therapy is the gold standard intervention, and there may be different strategies employed as part of therapy. Devices such as electrical stimulation can be used as adjuncts. Certain medications may be considered to help, for example, with recovery for patients with aphasia, the communication difficulties, or help with spasticity, which is an abnormal tone or stiffness which can develop in the arms or legs with time. Newer technologies may involve the use of robotics for training. Other emerging treatments include transcranial magnetic stimulation, which is depicted in the photo that's seen here on the screen. SGH is the first hospital in Singapore to offer repetitive transcranial magnetic stimulation as a service to help recovery in upper limb weakness for selected stroke patients. When there's residual weakness, adaptive interventions can help an individual to regain function. This can include assistive devices such as walking aids or ankle foot orthosis, or other devices like what's called a universal cuff, which essentially is a cuff that's placed onto a hand, which can be helpful for upper limb activities like eating. Another example is the use of technology to assist activities such as talking with speech to text translation instead of typing words. One of the roles of the rehabilitation medicine physician also includes prognostication. As mentioned, everyone's recovery can be different. So, what are some factors that influence recovery? Firstly, age. Generally, older individuals may not recover as well as younger individuals. There may be reduced brain reserves with age that affect the capacity for recovery. Of course, age should not be considered in isolation. For example, contrast someone who's a healthy 70 or 80-year-old who's fit and runs marathons with a younger person who might be in their 30s and 40s but has multiple medical problems or maybe even previous strokes. This is why other factors, such as the presence of other medical comorbidities or conditions, is important, such as whether they have diabetes and complications of diabetes, heart conditions, or kidney problems, for example, as well as how they were functioning before the stroke. Recovery would be different for someone who already requires assistance to move and walk before the stroke, compared with someone who was previously able to take public transport and go out to work. The severity of the stroke and its deficits also influence recovery. For example, the presence of cognitive problems would make recovery more challenging. Once again, the same stroke can affect different people differently, and hence treatment needs to be tailored. Locally in Singapore, rehabilitation can occur in different settings. There can be pros and cons to each, and there's not necessarily a right or wrong approach. One of the jobs of the rehabilitation medicine physician is to help advise on the ideal setting of rehabilitation, and this is usually in discussion with the therapist, the medical team managing the patient in the acute phase, as well as patients themselves and their families. Overall, rehabilitation is a multidisciplinary team effort. This beautiful mural, which can be seen in our rehabilitation ward, was jointly created by therapists, nurses, and doctors, and is a reflection of that teamwork. And now let's hear from the other members of our team. So I'd like to introduce Ms. Chu Yi-Tsing, who is a physiotherapist here at SGH, to talk more about physiotherapy and stroke recovery.
Hello, everyone. Thank you, Dr. Sangeeta, for the introduction. So, stroke survivors, as Dr. Sangeeta has mentioned, can often experience a wide range of impairment depending on the area and severity of their brain injury. This includes weakness, paralysis, loss of coordination and balance, sensory deficits, and cognitive and perceptual difficulties. This impairment can significantly affect their ability to perform everyday activities and participate fully in society. So physiotherapy plays a crucial role in helping patients regain mobility, independence, and confidence through early intervention, repetitive practice, and individualized therapy. So, physiotherapy begins as soon as the patient is medically stable. Early intervention is vital for optimizing recovery and preventing secondary complications such as contractures or deconditioning. In this slide, you see a comprehensive framework that we use to assess the stroke survivors' impairments, activity limitations, and participation restriction. This will help us to understand how the stroke impacted the lives of the stroke survivors on many levels. After gathering a thorough understanding of the patient's condition, we work collaboratively with patients, other healthcare professionals, and their family members to set meaningful and patient-centered goals. Our treatment plan is tailored to address the specific impairments while promoting functional independence and participation in daily lives. So physiotherapy intervention often starts with rebuilding strength and restoring movement patterns. So in this slide, there are many different figures that you can see. It can be gait retraining, strengthening, and balance work. So techniques such as neuromuscular electrical stimulation have been used to activate weak muscles, while progressive strengthening exercises help to build strength and endurance. We also use techniques such as proprioceptive neuromuscular facilitation, or PNF for short, truncology, and Bobaf technique to facilitate muscle activations, particularly in muscles that show minimal voluntary control to activate the muscles and normalize motor movements. Oh, sorry. So in this slide, you can see that this is a YouTube playlist that we have created a few years back in the rehabilitation ward. So this is called Arise, Assisting Movements in Stroke Patients. So this is an initiative that came out from our physiotherapy team to encourage caregivers, family members to engage stroke survivors in functional mobility in daily lives. So stroke survivors can engage in turning in bed mobility, seated exercise, and some standing exercises to promote functional recovery while they are still in the ward. You may also observe our therapists use external feedback such as mirrors and environmental setup to better facilitate the stroke survivals in their alignment and functional mobility. So if you're interested, you can search up Arise, Assisting Movement in Stroke Patients on YouTube for further look at these videos. So coordination and balance retraining are key components of rehabilitation, especially in patients that progress through functional mobility. Through balance exercises, gait training, and task-specific activities, we help to prepare stroke survivors for community mobility and a safe return to their daily and recreational activities. So in this slide, you can see that there is a tilt table and there's a bodyweight support harness with a treadmill walking. So for patients that require higher level of assistance, we incorporate the use of various equipments and device that helps us to continue and carry out our physiotherapy session safely. And these equipments help us to gain confidence in patients and allow them to be challenged in the right level during therapy session. So for the tilt table on the left, what patients typically do is that they'll be lying on the tilt table, and then the tilt table can be inclined up to 85 degree to allow patients to load on their legs and for motor contraction. So for light gait, similarly, is to offload the patient through deweighing so that the patients will be able to sustain their weight on their legs and be able to perform repetitive tasks such as walking on a treadmill. So another equipment that we use is also a Serra Plus and Agile Walker. So you can see in the video demonstration that they can do shifting in weight, scooting in bed, standing activities with the Serra Steady, and even walking. So this helps us as therapists to mobilize patients who require high level of assistance safely and maximizing patient therapy. So we also utilize robotic services in SGH, particularly free bionics, hybrid assisted limb, and local mat. So these robotic services are to enhance repetitive movement training, especially in patients that are unable to walk. This helps to promote mobility as well as to improve cardiovascular endurance and further encourage functional recovery. In some settings, hydrotherapy can also be utilized to allow safe movement in supportive water environment to promote mobility. So this is not practiced in SGH, but it's practiced in other hospitals as well. Okay. So overall, physiotherapy do play an important role in management of stroke recovery, and it's important to understand that every stroke survivors have different impairment, goals, and activity restriction and limitations. It is crucial for stroke survivors and family members to speak to therapists to understand patients' current functional mobility, to understand the appropriateness of the exercises and therapy interventions. It is also important for stroke survivors and family members to engage actively in their recovery journey to maximize the progress. So thank you for this time. I will pass over the time to Heidi, who will further share about what occupational therapy do in stroke recovery.
All right, thank you, Yiqing, for sharing what the physiotherapists do. Hello, everyone. I'm Heidi, and I'm an occupational therapist in SGH. Okay, so some of you may not have heard much about what an occupational therapist do. So over the years, I've heard quite a few misconceptions. Some people think we help others find jobs, while others assume we do the same work as physiotherapists. So in reality, our focus is quite different. Occupational therapists help people regain the skills and independence they need for everyday life. So occupational therapy comes from the word occupation, which simply means the activities we do in our daily lives. And these activities are what gives our day structure and meaning. So basic ADLs are activities that are necessary for basic self-care and for functional living. So the 6 main ADLs include dressing, feeding, transferring, toileting and showering, as well as mobility. You can imagine someone having a stroke to face difficulties with these tasks, and that's where OTs come in. Besides basic ADLs, there are more complex ones called instrumental ADLs. These activities may not be essential for functional living, but it improves one's quality of life and the ability to live independently. So when faced with a stroke, these tasks which incorporate higher order cognition will be even more challenging to navigate. So a stroke can affect someone in many ways. Two main components that OTs are heavily involved in are cognition and motor domains of the hand. So after a stroke, a person's thinking skills or cognition can be affected. They may face difficulty paying attention or staying focused for long periods. Orientation can be affected, making it hard to remember the date, place, or situation. Memory problems are also common, especially remembering new information or recent events. Reasoning and judgment may be reduced, affecting their ability to make safe decisions. And some may also struggle with problem solving, sequencing, or organizing tasks. And this makes daily activities more challenging for them. So a stroke can also affect the body's motor functions, the way we move and control our muscles. So strength can be reduced, causing weakness on one side of the body. Sensation can be impaired, making it hard to feel touch and pressure, or even the position of your limbs. Fine motor control, which helps people with small, precise movements, like buttoning or writing, can become very clumsy or very slow. Gross motor control, which is needed for larger movements like reaching or standing, can also be affected. So in addition, limited range of motion from the stiffness or muscle tightness can make daily activities difficult for them. As such, more often than not, our daily activities will be affected when one gets a stroke, as most of the things we do will require these domains. In rehab, there are two main approaches we can take. So the first is the restorative approach, which we focus on rebuilding or strengthening a person's ability so they can perform daily activities more easily again. So the second is the compensatory approach, where we teach patients how to adapt and work around their current limitations, using strategies, tools, or alternative techniques to still carry out what's important to them. So both approaches are equally valuable, and we often combine them depending on the person's needs and stage of recovery. So to showcase what an occupational therapist typically do, I'll take you through two case studies. So first case, Mr. B. Mr. B, a chef, comes in for a left-sided pure motor stroke while he is at work. So this meant that his right hand is weaker now. He's unable to feel surfaces well, indicating his sensation was affected. When he tries to pick things up, it keeps dropping. And when he tries to move his hand, it shakes quite a lot. And this shows that his motor control is quite poor. So these challenges makes it hard for him to perform precise coordinated hand movements that his work requires as a chef. And these are some upper limb interventions we can carry out for Mr. B. So we use targeted exercises to activate the weaker muscles, improve joint movement, and reduce stiffness. So this includes gentle stretches, resistance training, or using weights or resistance band. As the arm gets stronger and gross motor control improves, we slowly progress to more fine motor tasks using the hands. So the picture on the bottom right shows a mat that we can loan to patients in the ward to do target reaching practice. So I often leave these mats with suitable patients because practicing outside of therapy sessions help to reinforce the exercises. It also encourages consistency and builds the habit of daily exercises for them. So we also retrain the hand and finger control so Mr. B can handle small and precise tasks again. So we can start with gentle movements to improve the coordination, like picking up coins, turning pegs, or squeezing stress balls. So these exercises help the brain and the hand to reconnect, thereby improving the speed, accuracy, and strength. So having good control of our hands is crucial in doing daily activities. As control returns, we move on to real life skills like buttoning clothes, writing, or using utensils, and this helps him to resume his life roles again. So because his sensation is affected, we do sensory retraining to help him feel and control his hand better. Sensation helps us to feel textures and pressure, and it's something we often take for granted. So when this sense is lost or altered, simple tasks like buttoning clothes, using a knife, or holding a cup can feel strange or unsafe. So through sensory retraining, we use different textures and objects to help the brain to relearn how to interpret touch. He is guided to focus on what he feels and to recognize the sensations accurately again. Sensation also provides the feedback loop for the brain to control the hand better. So sensory retraining is as important for a stroke patient as strength training. And this helps improve the hand awareness, safety, and confidence in daily activities. As OTs, we don't just focus on muscles, we also focus on the functions of the patient. So after the stroke, daily activities can become challenging due to his weakness, poor coordination, and reduced sensation. So for this, I begin by breaking each task into manageable steps and provide guidance. So the goal is to help him regain the independence and confidence so he can take care of himself safely and efficiently. So ADL retraining is key to helping him return to his normal routines and meaningful roles such as being a chef. Okay, now we move on to the next case study, Mr. C. Okay, Mr. C was admitted for following a left-sided stroke, and as a result, he showed slowed processing speed. He frequently forgot day-to-day information. In addition, his right hand becomes very weak. So it makes him difficult for him to lift up or even move his arm effectively. So the stroke has impacted both his cognition and the motor abilities, and this affects his independence in daily activities. So here are some interventions we can carry out for Mr. C. So firstly, I might prescribe an arm sling to support his hemiplegic right hand and protecting it from injury and reducing the risk of shoulder joint complications or deformities. So in addition, if Mr. C is unable to move his right ankle on his own, I may prescribe a resting ankle foot orthosis, and this helps to prevent the stiffness and support proper positioning to protect his joint during recovery. To help Mr. C strengthen his upper limb, electrical stimulation can also be applied to the muscle supporting his shoulder as well as other key muscles in the arm. So this helps to activate weak muscles, improve movement, and support functional use of the limb during recovery. So this shows a pictorial representation of the electrical stimulation. So electrical stimulation sends signals to the nerves and muscles in the hand. So these signals makes the muscle contract, causing the hand to move. It helps awaken weak muscles, improve the circulation, and remind the brain how to move the hand again. And so to prevent stiffness and maintain full range of motion for Mr. C's upper limb, I would also help him perform guided movement, encouraging him to assist with the exercises if he's able to. When caregivers are present, I typically teach them how to assist with these movements as well. And this allows more frequent practice outside of therapy sessions, helping to keep the weak arm mobile and support recovery over time. So sometimes full recovery of the upper limb may not be possible after a stroke. And in such cases, I would teach Mr. C hemiplegic techniques to perform his basic ADLs as a form of compensation. So for example, when putting on a shirt, I may teach him to thread the garment through the weaker arm first, followed by the stronger arm. And the same principles can apply to putting on pants. So learning these new habits and procedures also provide valuable practice and repetition, and it helps them to become more confident in daily tasks despite their limitations. Because Mr. C had some cognitive deficits, I would also focus on practicing instrumental ADLs with him. So this includes tasks such as understanding medication labels, simulated medication packing practices with pillbox, and using health apps like Health Buddy to find his upcoming appointments. So some compensatory strategies such as setting regular phone reminders can also be taught to ensure he can manage his daily routines even with the cognitive challenges. To support Mr. C's return home equipment may be recommended. So for example, a wheelchair may be prescribed if he's unable to walk the required distance at home or in the community. A mobile commode can also assist with toileting and showers to facilitate his ADLs. Home modification may also be recommended for Mr. C, especially if his HDB has 2 steps at the main entrance, which can make it difficult for him to enter the house after his stroke. So by installing a ramp, his wheelchair can be wheeled directly inside, making it more accessible. Grab bars can also be added in the toilet and shower areas to provide additional support during basic ADLs like toileting and showering. So for Singaporeans living in HDB apartments, these modifications can be supported through HDB Ease, which provides these services at subsidized rates. Finally, a caregiver training is an important part of Mr. C's rehabilitation. We can train his helper to assist with basic ADLs, instrumental ADLs, and transfers. So ideally, as OTs, we will encourage patients to do as much as they can independently at home. But when this isn't possible, caregivers play a key role in supporting daily routines and to facilitate discharge home. So in addition to the equipment and orthoses mentioned earlier, there are some other items we may prescribe for other stroke patients. So these are carefully selected based on each individual's needs. Typically, the OT in charge will recommend the appropriate equipment to the patient and their family after thorough assessment and therapy sessions. So items like hospital bed, air mattress, geriatric chair, personal mobility aids like motorized scooter or wheelchair, or portable bed rails. And other instrumental ADLs we can assess and practice with patients include community mobility. And this provides an opportunity for patients to practice essential skills such as wayfinding using signboards, purchasing items at the food court or 7-Eleven, and managing money, which also includes withdrawing cash at ATMs. So these skills are critical for independent living. So when it's appropriate, I do take patients out to the community to practice with them in real life setting. So to conclude, OT's role goes beyond exercises or equipment. We do look at the person as a whole, assessing their physical, cognitive, emotional, and social needs. So our goal is to help them regain independence and return to meaningful daily activities, which matters most to them. So we recommend practical strategies, adaptive tools, and environmental changes to support their recovery journey. Above all, we advocate for each individual's participation, dignity, and well-being, and to ensure that every step in their rehab brings them closer to living life meaningfully again. So thank you, and now I'll pass on to Ms. Afika to showcase what a speech therapist can do.
Thank you, Heidi. Hi, everyone. I'm Afika. I'm a speech therapist here in SGH. So today I'll be sharing a little bit more about the role of the speech therapist, in stroke rehabilitation. So we'll be going through the role of the speech therapist, the swallowing difficulties, and also communication difficulties. As speech therapists, actually, one of the common misconceptions on what we do is that we mainly help patients with only speech difficulties, but we do more than just that. We also help to diagnose and treat swallowing difficulties, communication difficulties, and also cognitive difficulties. So swallowing difficulties, or what we term it as dysphagia, is basically difficulty with swallowing, and some of the common symptoms that we can identify or see when someone has difficulties with swallowing is that they may experience coughing and choking or onset of breathlessness. This can occur before, during, or after meals. There may be unexplained weight loss. You may hear like the patient's voice being gurgly or wet. They may have difficulty chewing because there may be some weakness after the stroke, and hence also impacts their ability to chew the food thoroughly. There may also be a sensation of feeling something stuck in their throat whenever they're eating or drinking something. So following a stroke, there may be changes to a patient's swallowing, be it due to changes in their cognition and or weakening of their swallowing muscles. So this puts them at a risk of what we call penetration or aspiration of food and drinks, meaning that food and drinks go into the airway instead of the esophagus, which is your food pipe. So when this happens, patients may get a chest infection, which can be life-threatening. So what our body does as healthy individuals when a foreign substance enters the airway is to cough it out. But for some stroke patients, their ability to do this may be reduced, or they may not be able to do this at all. So when do we come in? When the patient is identified to have dysphagia, the team doctor will refer them to us for us to do an assessment. So we start off with what we call a bedside assessment, whereby we test out a patient's swallowing using different consistencies of water and food to ascertain what is safe for them to swallow. So sometimes fresh after a stroke, when their swallowing is affected, we do want to keep them on something that is safe for them to eat and drink to also ensure that they do not develop a chest infection. So the water and the food that we test out during our assessment and eventually recommend to patients follows the International Diet Dysphagia Standardization or the IDSI. So this is a common language that allows for standardization of food and water recommended for patients if they need to be on these modified forms of diet and also fluid or water consistencies. So I'll show you shortly what some of these modified water and food looks like. So here is an example of some of the different levels of water consistencies that we may try out during our assessment with patients post-stroke. So you can see as we go up the consistency level, so from level 1 all the way up to level 4, the water gets thicker in nature and it appears more jelly or even pudding-like. So a thicker consistency of water at times is required for patients post-stroke because this consistency might flow slower, giving the patient time to swallow the fluids safely and preventing it from going into the airway quickly. But this is, of course, only one of the various or many explanations that can be used for the use of thickened fluids, and it really depends on a speech therapist or an ST's assessment and eventual recommendation. In terms of food and diet levels, you can see here also the different levels of the modified food and diet levels. And similarly, as we go up the diet level, the food gets closer to what most of us as healthy individuals may be able to consume from day to day. So you can see we can start off from level 3 liquidized diet, which is basically similar as for your level 3 fluids. You also have your level 4 pureed diet, which is there's no lumps in it, and level 5 mince and moist, which is kind of similar to your sort of minced meat. You also have your level 6 soft and bite-sized diet. So typically for this type of diet, the sides or your meat and your vegetables is cut up into 1.5 by 1.5 cm in terms of its size. And you also have your level 7 easy to chew diet. It still requires a bit of chewing, but it's softer in general. And generally, we tell patients to also avoid crunchy, hard, or dry textures. So as you can see, as we go up the diet level, also it's closer to what we would normally consume as individuals. So some patients post-stroke, they might find difficulty with chewing your regular food. So you can think of things like your biscuit, your fried chicken, because of their swallowing muscles being weaker, this might be a difficulty for them, and hence they need these modified foods. And we will recommend it accordingly after our assessment. Aside from bedside assessments, we also may recommend and conduct what we call an objective assessment. So there are two different types of objective assessments where we may suggest if we want to get a more detailed understanding of a patient's swallowing profile. So we have the video fluoroscopy swallow study, or the VFSS, and the fiber optic endoscopic evaluation of swallowing or fees. So a VFS is basically like a chest X-ray. It's just that during this procedure, the patient consumes food and drinks that are coated in barium, so that we are able to basically visualize how the food and drinks are going down and whether or not they're going down the right way. Whereas a fees is where you basically have a scope inserted through the patient's nose, and you also visualize the swallowing structures. Similarly, they also take food and drinks, and for us to visualize whether or not it's going down the wrong way, the right or the wrong way. So as mentioned earlier, our body would usually respond to foreign substances in the windpipe by coughing it out. But for some patients after the stroke may also impact the important nerves that gives them that sensation, and hence feedback to the brain to cough things out. So this is what we call silent aspiration, and that's why it's also quite dangerous. And it's not something that we can pick up from our bedside assessment. So things like an objective assessment in this instance is also especially important. So in terms of how we as SDs manage dysphagia or swallowing difficulties, so like I mentioned, so after we assess, we might suggest modified diet and fluid consistencies. We might change what we call the bolus size, or basically the amount that you suggest to feed the patient or your loved one. So be it feeding them by teaspoon, tablespoon, or cup, changing the feeding method or other feeding strategies. In the instance where the swallowing difficulties is quite bad, we might eventually recommend non-oral feeding or tube feeding, basically. So two forms of it would be nasogastric tube feeding, or NGT. So you can see here in the graphic here, where basically a tube is inserted into the nose, and that's where the supplements is being fed through in order for it to go to the stomach. Another option is what we call PEG tube, which is inserted through the stomach. So this is in the instance where the patient really is not safe to take anything by mouth. So other feeding strategies that we might recommend would be to get patients to swallow before taking the next mouthful, a cough swallow, a whole swallow, or other things like chin tuck and a head turn. But of course, this is up to a speech therapist recommendation, and we will recommend it accordingly based on our assessment. Feeding strategies may also be recommended and become necessary. For example, feeding a patient while lying down may increase the risk of choking, and hence we would always recommend for them to be seated in an upright position. Moving on to communication difficulties, exchanging information and ideas, and it involves both the ability to understand and express information. When this ability changes after a stroke, patients may find it challenging to communicate even the simplest things like, going to the toilet, asking for something to eat or something to drink. So as STs, these are some things that we diagnose and also treat. So we may diagnose and treat aphasia, as mentioned earlier. So it involves difficulty with understanding and or expressing self in the written or verbal form. So there might be difficulty with reading, writing, listening, or talking. Dysarthria. So you might see that, so this is difficulties with articulating self in a clear manner due to the weakness in muscles post-stroke involved in speaking. So in this instance, sometimes you might hear someone sounding very slurred, having a soft volume, or they might not be able to really control how fast or how slow they talk. We might also see patients with apraxia of speech. So this involves one's ability to coordinate and sequence movements to produce speech. So you may see that some patients produce a different sound than what was intended to. For example, when they're trying to say the word bin, they might say bun or bud instead. And in some severe cases, some patients may not be able to produce any sound at all. We might see patients with dysphonia, or what we call voice disorders. So this might also lead to changes in their voice quality. It can sound a bit rough, a bit breathy. You can hear differences in pitch or even loudness. And lastly, what we call cognitive communication difficulties. So this cognition again refers to your thinking processes, so things like your memory and attention, which the OT also plays a part in. And difficulties with attention sometimes can also impact communication. For example, it may look like the patient simply is not able to pay attention to what is said to them or wander off during conversations. So some communication strategies that we might recommend, because we recognize that communication does not always fall on the patient themselves, but by STs we also want to advocate and info counsel caregivers on the ways that they can facilitate communication with their loved ones. So some general strategies is to provide options, repeating keywords, reducing any distractions so that the patient is able to focus and understand the conversation. Drawing or even writing down some information or keywords. Sometimes you might also ask caregivers to slow down, supplementing communication using things like gesturing and facial expression, and also using short phrases. So that's the end of my presentation. I'll now pass the time over to Estelle, the music therapist, who will be sharing more about music therapist's role in stroke patients.
Thank you, Afika, for the sharing. Hi, everyone. My name is Estelle, and I am a music therapist here at Singapore General Hospital. Today, I will give you a glimpse into the role of music therapy for communication, movement, and emotional well-being. Well, and I think music is best understood in an experience, so I will be singing a song for everyone. Hopefully, it's familiar to most of you. I think there's about 400 of you online now. And when you're listening to the music, perhaps you can take a moment to notice what is your body doing and what do you feel, if you're feeling anything, okay? When the night has come and the land is dark and the moon is the only night we'll see. No, I won't be afraid. No, I won't be afraid. Just as long as you stand by me. So darling, darling, stand by me. Oh, stand by me. Oh, stand by me. Stand by me. Darling, darling, stand by me. Oh, stand by. Stand by me. Stand by me. I'm sure you noticed something when I suddenly stopped, right? Okay, just keep those reactions and keep those observations in your mind, and I will explain more later. So, what is music therapy? Perhaps for some of you, this is the very first time that you are hearing this term. So, according to the Association for Music Therapy in Singapore, music therapy is the scientific use of music interventions within a therapeutic relationship towards observable, measurable, functional, educational, rehabilitative, and well-being outcomes by a credentialed professional. In short, if I can deliver this in a diagram instead, basically there are three elements to music therapy, being music, the therapist, and the patient. And all these three elements are meeting together, interacting with each other to improve health outcomes. Now, who is a music therapist? Music therapist is someone who has studied at a degree, either at the master's, most of us have studied in the master's level, a degree in music therapy, and we have clocked a certain number of clinical hours. In some schools, it's about 900. For myself, I clocked 1,200 according to the American board. And we are credentialed therapists who are trained to use music for such specific individualized goals and health outcomes. Yeah. So why music? I think we have experienced a little bit about what music can do to us or how we interact with music. So basically, music is processed, activates the whole brain. So the brain processes the sounds that you hear, right? And hearing the music may make you want to feel like moving. So maybe just now when you hear the music, you might find yourself bobbing your head, moving your shoulders. Some of us might be tapping our feet or clapping our hands, right? Some of us might want to smile. And listening to certain songs may make you think of certain events in the past of familiar people. Perhaps if those of us friends who are in the era of Stand By Me, you might remember the music video or you might have watched a concert live. So listening to music may trigger that part of the brain. And of course, there are so many other parts of the brain that is triggered, and music basically connects both sides of the brain. Yeah. So this is why we use music. And some common needs of stroke patients that are supported by music therapists. I think you have heard from my colleagues just now. So we work in the area of communication, for example, aphasia, apraxia, and dysarthria, like what my colleagues have shared previously. We also work with stroke patients with movement disorders, so they have poor coordination of the gait, as well as, of course, providing that emotional support that our patients may need. Okay. And in SGH, a doctor's referral is necessary to access music therapy. So a common approach taken by music therapists is neurologic music therapy, which is driven by neuroscience. And neurologic music therapy is supported by two main principles. The first principle is of rhythmic entrainment. Basically, your body naturally synchronizes with external rhythm, and this rhythm coordinates movement. I wonder if there are some of you who maybe have been to Don Don Donkey and you feel like you're moving to the beat of the song. Maybe some supermarkets, they play faster music so that you can get out of the supermarket as soon as possible. And in hotels, it's usually much slower because they want you to chill and relax in the lobby, right? So this is the principle of rhythmic entrainment, and that's what we use in music therapy primarily. And of course, the second principle is what you already know, which is neuroplasticity, where the brain is able to reorganize the neural pathways after an injury. So now, in the field of communication, when we reflect about speech and singing, they share so many similar neural mechanisms, and both of them also share muscles of respiration and articulation, right? When you're singing, there's lyrics and you want to articulate your lyrics so that you can be heard and understood, and that is very similar to speaking. So some of the key interventions that we use would be using rhythmic speech cueing. Basically, we provide a tempo or steady beat for our patients to improve the clarity of the speech. And of course, another intervention that we may use is called melodic intonation therapy, where we use melodic and rhythmic elements which model speech inflections, right? So rhythm and music engage the undamaged right side of the brain, which bypasses the damaged left side of the hemisphere. And this is activated through the left hand tapping, which is controlled by the same motor control network. So essentially, singing can help to improve speech. Okay. And in the field of movement, as experienced now, rhythm really organizes movement, and the music therapist may provide live rhythmic cues to match the walking pace of our stroke patients. Yeah, and this is done through rhythmic auditory stimulation, where we are providing the cues as an external stimuli to help patients regain a more equal gait. Like it might go like left, right, left, right, okay, something like this. And in a ward, you may even notice a music therapist working closely with a physiotherapist supporting the stroke patients. Yeah. Okay, and finally, part of the holistic care provided to patients here includes that of emotional health and well-being. Stroke is a life-changing medical condition that patients must adjust to and live with, and emotional well-being directly impacts rehabilitative outcomes. So some of the psychological impact of stroke could be profound, and patients may experience grief, frustration, anxiety, or depressive symptoms. And these are really natural responses that could significantly hinder rehabilitation if it's left unaddressed. And music therapists use music as a resource of therapeutic support to help patients process these changes. Okay, so the music therapists basically build on preserved abilities and strengths of our patients while tapping into the personal meaningfulness of music. So how music is meaningful to individual people. And we do it through active music making or receptive music experiences. So by listening, talking about songs, we provide a safe space for patients to express their emotions and experience the healing. Yes. So a medical crisis, whether temporary or chronic, can lead to physical, emotional, social, cognitive, I'm struggling with this, and spiritual changes. Okay, and the music therapy allows individuals to identify, explore, or develop new ways of coping, experiencing, relating, or living in a safe and supportive environment. So in conclusion, this presentation provided just a glimpse of the work of music therapy in stroke rehabilitation. We work closely with the patients and their caregivers, as well as our colleagues in the multidisciplinary team to achieve the best health outcomes for our patients. And we use music as rhythmic or melodic stimulus or as a resource to support these individualized goals. And with that, I'll pass the time on back to Dr. Sangeeta to round up the webinar.
So firstly, thank you, Estelle, for that really engaging and insightful talk. Now we'll move on to the last section of the webinar. So earlier on, we talked about some of the common impairments that people face after stroke, from weakness to cognitive problems. Beyond this, there can be, as mentioned, social and lifestyle impact from stroke, with changes to independence, employment, and relationships, which also ties in with our sense of self and self-esteem. It's not uncommon to have low mood or feel anxious after a stroke, especially when there's been a change to our usual way of life. Sometimes these mood changes may even be directly related to the stroke. There can also be personality changes after a stroke, which can also be a source of stress for relationships with our loved ones. This can have impact on quality of life and even the recovery process itself. So how we pick up the pieces, face the problems, and rebuild life is important. People manage emotions in various ways, and each person copes differently. Sometimes specialized help may be needed. So as mentioned earlier, through Estelle's presentation, therapies like music therapy can be helpful. And sometimes we may need to consider things like medications for mood or counseling. Other issues can also arise after a stroke, Spasticity is a common condition where there are tight or stiff muscles with difficulty moving the limbs. There can also be involuntary movements as well, and it can sometimes cause pain and affect function. As you can see in this video on the right, sometimes there's difficulty in this video when I try to stretch this patient's fingers open. Depending on the severity and location, there can also be concerns of hygiene. For example, if it affects areas like the armpit or the groin with risk of infection. If spasticity causes altered positioning, over time, these changes may become permanent with muscle shortening, what we call contractures. Stretching is an important way to manage spasticity. Sometimes medications may be required to address spasticity, especially if it causes pain and affects function. These medications may be either tablets or injections. So, as you can see in the video on the right, after injections were done for this patient, it is easier for me to stretch the fingers. Shoulder pain can also occur commonly after a stroke. There can be multiple reasons why someone has shoulder pain. The rotator cuff refers to a set of shoulder muscles, and there can be issues with inflammation or strain of these muscles. This may be related with training or sometimes abnormal positioning, which is also in turn related to limb weakness. Frozen shoulder, where there is limitation of the range of movement, can also occur. Pain can even occur as a consequence of stroke, depending on the area of the brain affected or involvement of nervous signaling pathways, what we refer to as central pain. There is really a long list of possible causes of shoulder pain, which I will not delve into. Scans may be required to determine if there is injury to shoulder muscles or signs of inflammation. Apart from doing targeted therapy, pain relief measures may include topical gels or creams to rub onto the skin, tablet medications, or even shoulder injections, which can be done by rehabilitation medicine physicians. Stroke can recur, and in order to try to prevent a second stroke, it is crucial to continue with prescribed medications like blood thinning medications and maintain follow-up with primary care doctors to control risk factors like cholesterol, diabetes, and blood pressure. Nutrition is also important and to aim a balanced diet. Finally, engaging in exercise where possible is also key, especially to help prevent a sedentary lifestyle and avoid decline. Moving on, goal setting is an essential part of rehabilitation medicine. It considers your life and what matters to you. These goals are dependent on multiple factors. The diagram on the right is a framework model that is the basis for the World Health Organization International Classification of Functioning, Disability, and Health. It shows the interplay between the health condition at the top, impairments in body structure and function, limitations in activities like self-care, and participation in community activities, as well as contextual factors like environment and personal factors. Each person would have their own set of factors and each interplay in their own unique way. So it highlights the need to individualize goal setting. In rehabilitation medicine, we believe in setting SMART goals, which are specific, measurable, achievable, realistic, and timely. These goals will shift and adjust along the way depending on progress made. For example, during the hospital stay, the initial focus may be towards being able to manage, firstly, in the home environment with basic self-care and perhaps maybe walking. Subsequently, it may be about participating at a community level, returning to work or school, driving, other recreational hobbies, and even social roles as a parent, as a husband or wife. Even patients with deficits after stroke may still be able to return to driving with some adaptations, although they would require formal driving assessments by our occupational therapists. Overall, discussion about goals involves a continuous dialogue between the rehabilitation medicine team and our patients. As mentioned, everyone recovers differently. In cases where someone has sustained a severe stroke and is perhaps bedbound with high care needs, the goals would be different. The focus would be on ensuring proper care and preventing problems associated with reduced mobility, such as pressure sores. This would also involve preparing the home environment and equipment, such as air mattresses, special wheelchairs, or even things like a hoist to help with transfers, as elaborated earlier. Training with assigned caregiver would be done to manage the basic activities like feeding, if they are on tube feeding, and toileting, which may involve changing diapers, and showering or sponging, and regular turning as able. In some cases, especially when there is no available caregiver, a nursing home may need to be considered to support nursing care needs. The role of a caregiver is not easy. It can be stressful, and there is a need to provide support for the caregiver as well. Caregiver training can build confidence in managing care at home. Lastly, I would like to take the opportunity to highlight the Singapore National Stroke Association, which is an excellent avenue for more support and information for stroke survivors as well as caregivers. They organize activities. In fact, their annual Stepping Out for Stroke walk will be happening this weekend. There are also volunteer options for public, and I would encourage anyone who is interested to explore this further. Stroke Hub, a section of Health Hub, also has some additional information on stroke. These are some resources from MOH. For any stroke patients or families facing any financial difficulties, there are healthcare financial schemes available in Singapore, which you can explore more about through the AIC or Agency for Integrated Care. Alternatively, you can always speak with a hospital or community social worker. So overall, thank you so much for joining us today. I hope this has been an informative and helpful session to give you a glimpse into what we do as part of stroke rehabilitation. If you have any questions, please ask your doctors for a referral to see rehabilitation medicine. Thank you.